Hi, my name is Monica Welga, and I am discussing infant mortality in Louisiana as a policy specialist. Low-income populations in Louisiana lack maternal support and access to non-emergency maternal and child health care services, stimulating high infant mortality rates. Socioeconomic status and disparity play a large public health role in this issue. With so many women in Louisiana on Medicaid or uninsured, preventative care is very limited because of the majority of low-income policies are for catastrophic events only. This delays seeking care and causes otherwise preventable complications. Louisiana has also developed a culture of electing for C-sections prior to full term. Louisiana is ranked second in preterm births and has over 1/3 of births from C-sections. Both elected and medically necessary C-sections can cause low infant birth rates and a major factor in infant mortality and other health complications that can be fatal. There are also several sociocultural and community perspectives involved. In the United States, work sites and school sites are a leading barrier for exclusive breastfeeding. Even if the birth goes well, reduced immunity and other health risks from not breastfeeding can stimulate infant mortality during their first year of life. Reduced lactation areas further diminish the social norm of breastfeeding and hinder breastfeeding rates. Neighborhoods are also a major indicator of life expectancy and birth outcomes. Unsupportive work and school environments are just continuing the cycle of poverty. There is neither one cause nor one solution for this issue, so let's examine this socio-ecological model and explore its multiple dimensions. On an individual level, gestational weight gain, especially in the third trimester, stimulates growth of the child to prevent low birth weight, a major concern and factor in infant mortality. Interpregnancy interval, or IPI, is a strong epidemiological marker in predicting preterm births. Shorter IPIs increase the risk of low birth weights. Interpersonally, increasing breastfeeding rates is a tremendous opportunity. Having a positive breastfeeding culture and family encouragement improve breastfeeding outcomes, and higher breastfeeding rates have been correlated with reduced infant mortality rates. Infant mortality rates are nearly 2 times higher in African American children than Caucasian. Racism can reduce social support and access to providers, which leads to unnecessary health complications. Public education programs are an organizational level benefit that provide one-on-one interactions, home visits, personalized care, and health education. Similar material presented in classes or in conferences have not shown as much benefit as when conducted in a home visit approach. The Affordable Care Act, or ACA, has definitely improved insurance coverage rates, but the specific plans themselves tend towards emergency-only coverage, which overlook a lot of preventative care. Progesterone therapy, for instance, reduces rates of preterm births, but it's not a covered benefit through the ACA and is very expensive out of pocket despite its benefits. Rural and inner-city communities in particular benefit from community-based interventions. Programs that are outcome-based and culturally sensitive have more community engagement and more member-centered programs. Worksite support is a major hindrance in reducing infant mortality rates. Unpaid maternity leave is just increasing disparities since it's only available for those who can afford it or those who have higher level careers with the benefits. Maternity leave has shown to have slightly higher and healthier infant birth rates, reduced risk of preterm births, and dramatic improvement in infant mortality rates. A health and all policy approach is very valuable and effective in maternal and child health. After the Jim Crow laws were abolished, infant mortality rates decreased in the U.S. Black population specifically. Human rights and equality legislature can strengthen access to care and in turn maternal and child health. State minimum wages is another political influence on infant mortality rates. Black infant mortality rates in particular benefit from increased minimum wages. Unfortunately, Louisiana does not have a state minimum wage. Women must work longer for a living wage, and there's less time and money allotted into maternal and infant care, proper nutrition, and stress management. To overcome these challenges and, of course, capitalize our strengths, my first proposed intervention is Right to Feed Louisiana. This will require state-sanctioned workplace and education sites to have clean RTF-certified lactation areas designated for nursing mothers. This will aim to overcome leading barriers of work and school for exclusive breastfeeding. Since breastfeeding shows such promising improvement in infant mortality rates, another aim is to improve the widespread social perception of breastfeeding. We will primarily address the individual, interpersonal, and organizational level of the socio-ecological model. To evaluate this plan, we will have pre- and post-intervention validated random sample surveys, which include men and women from 15 to 45 years old. These will evaluate perceptions of breastfeeding, exclusive breastfeeding barriers. Data collection will also be done in women's health clinics for breastfeeding rates. Success of the program will be established based on the breastfeeding rates and whether they increase, and the perception of breastfeeding as a social norm. One challenge of this plan is that it concentrates on state workers and student mothers. The outcomes of this intervention, however, can be used to further develop breastfeeding initiatives and work to assess the impact of lactation rooms. The aim is also to improve the social norm of breastfeeding, which is a widespread influence. Second, we have the Maternal Care Act. This act expands preventative maternal care and postnatal care for the infant's first year of life to the mothers on the ACA minimally insured plans. The focus of this act is to reduce avoidable complications by not prolonging seeking care and improve ongoing health education through several steps of pregnancy and postpartum. This is primarily an organizational level approach. Pre- and post data collection will be done to assess the rates of prenatal care visits, maternal emergency visits, and the cause of death within the infant mortality rates. Success of this plan will be established based on these findings and whether there is an increase in prenatal care, reduction of emergency care for maternal-related issues, and a reduction of preventable health-related infant death rates. One challenge of the Act is to be sure that outreach to the qualified parties is done appropriately. The Act will have designated team to notify the women of childbearing years within a specific level of the ACA coverage and develop outreach material for women's health clinics. The third and final proposed intervention is Louisiana's Maternal Support System, or LAMS. The system provides home visits for vulnerable pregnancies and their postnatal care for their first year. This can achieve transportation barriers for expecting mothers, address medical concerns in a timely manner, and improve maternal and child health education. This works primarily with the individual and community level of the socio-ecological model. To evaluate this system, we'll have a validated survey and interview for the mothers on best feeding, sleeping, and care practices for both themselves and their infants when they enter and when they exit the program. This will establish the potency of the educational material and will judge the success of the intervention. We'll measure based on the markers to see the improved recognition of maternal and child health concerns, reduce elected C-sections, and increase breastfeeding rates. Challenges include patient follow-up, follow-through, and participation. One solution, though, is to establish financial incentives for medical providers and how many of their qualified mothers are participating in the program to influence patient outreach and support. Low-income populations in Louisiana lack maternal support and access to non-emergency maternal and child health care services, creating high infant mortality rates. If we increase lactation areas in the education and work sites, then we can have improved breastfeeding rates and greater nutrition status of infants. If we expand maternal preventative care in low-income populations, we can identify health risks early and reduce unnecessary complications. If we provide home visits for vulnerable mothers, we can overcome barriers of care and provide culturally sensitive education. These will create lasting impacts for the mothers, children, and their health culture. We must create policies to cultivate a viable infrastructure and environment for these programs, allowing mothers to provide for themselves, their children, and in turn, our community. Thank you.